Hello, I'm Robert Purchase, an orthopedic surgeon here in San Francisco, California, with a specialty in shoulder surgery and sports medicine. My comments are intended to help you understand how orthopedic surgeons use cortisone injections and inform you of some of the basic considerations of their use. Thank you for your interest in this topic. Please bear in mind that this is a huge topic, and by the very nature of this forum, I will talk in broad generalities, and there are unique situations that are not addressed by my comments. Despite this fact, I hope that you find this quick 6-minute video informative. Cortisone has many uses in medicine in general, but it has a prominent role in the treatment of many musculoskeletal conditions. Cortisone is a common term, not a specific medication. It refers to a whole class of medicines called corticosteroids. Corticosteroids are a class of medications that are synthetic derivatives of the naturally occurring hormone cortisol. Within this class of corticosteroids, there are specific types, such as Kenalog or dexamethasone. While each product has unique features and your doctor may choose one in certain situations and use another in a different scenario, these details are beyond the scope of this video, and I will refer to all of them generically as cortisone. As an orthopedic surgeon, an injection of cortisone is a non-operative option for a great number of diseases I treat, from neck problems to toe pain. We commonly use it for spine problems such as disc herniations, arthritis at any joint, and inflamed tendons in the shoulder, elbow, and hip, and in all sort of unique conditions such as trigger finger and frozen shoulder. I believe that its ubiquity can give the impression that its use is somewhat random, that the doctor is using it without a clear idea of the exact entity that they are treating. While this is a valid approach when the diagnosis is less than clear, I suggest that the vast majority of the time the orthopedic surgeon has a clear idea of what they are treating and how the cortisone will help. Let me give you a clear example of what I mean. It's not uncommon for me to discuss a cortisone injection for my patients who come with many different types of shoulder pain. Two common problems that I may treat with an injection include rotator cuff problems and adhesive capsulitis, and these are two completely different diseases. In adhesive capsulitis, the injection is likely to be essentially curative, while the injection is just a part of a larger treatment plan for rotator cuff problems. However, if I, the doctor, fail to explain this well enough to the patient, I understand how this treatment could be perceived as generic. Now, cortisone is a powerful anti-inflammatory. A lot of the musculoskeletal disorders have at their core an element of inflammation. In these situations, I think of the inflammation as a fire and the cortisone as a fire extinguisher. Hopefully, the cortisone puts the fire out. Now, cortisone injections have several different clinical effects or outcomes. In certain situations, they can essentially be curative as a standalone measure, such as trigger finger or frozen shoulder. In other situations, they are complementary to the other non-operative measures. A good example of an injection as a part of a treatment program is rotator cuff tendonitis. As a standalone measure, an injection is likely to provide only temporary relief. But physical therapy can fundamentally change the way the shoulder works and provide durable pain relief. Unfortunately, some patients are so affected or limited by their pain that they cannot participate fully with the PT. And in those situations, an injection can be a kickstart, a little push, so that the patient can tolerate the PT better and just get better faster. Interestingly, sometimes injections can provide some diagnostic information as well. For example, it can be difficult to assess if someone is having shoulder pain from a shoulder problem or from a neck problem masquerading as a shoulder problem. In those situations, a patient's response to the injection can provide valuable diagnostic information, meaning that if the patient received no relief from a shoulder injection, one explanation is that the patient has a neck problem. Clearly, this is good to know before considering ongoing treatments for a presumed shoulder problem. Alright, while chronic corticosteroid use when taken as a pill can cause unfortunate side effects such as weight gain from water retention, these kinds of side effects do not happen after a single injection or even after judicious, repeated use of injections spread out in time. A cortisone injection does temporarily impact the way your body processes sugars. If you're not a diabetic, your body can easily adapt. On the other hand, if you are a diabetic, you will likely notice a bump in your blood sugars for a brief period of time after the injection. There's a very small chance that you can experience a reaction to the medication that is temporary and annoying, such as facial flushing, and at the injection site there are two cosmetic complications that rarely happen. Sometimes a dimpling of the skin can occur at the site of the injection. Also, there is a small chance that you may develop a round area of decreased skin pigment at the site of the injection, best described as vitiligo. In the unlikely event that this occurs, the cosmetic changes may be permanent, but are unlikely to cause a functional deficit. Now, these injections are very safe. The number of these types of injections that are performed every day across this country is astounding, and most orthopedic surgeons never have a patient of their own experience a significant adverse event from them during their entire career. But, like everything in medicine and life in general, the risk is not zero. Beyond the potential side effects of the medicine, there are few potential adverse events. There is the discomfort of the procedure itself, which I'll come back to, and there is the risk of infection. Obviously, your doctor will clean the skin thoroughly prior to the injection and use standard sterile techniques, but preventative antibiotics are not necessary. The one myth that I would like to do away with is this idea that steroids will ruin the joint. While it's not generally advisable to inject steroids directly into tendons, there is no good scientific data to suggest that judicious use of cortisone will cause degeneration or arthritis of the joint. But having said that, I try to use steroids conservatively, especially in younger patients. I think that's just good medicine. To do the injection, the doctor will put you in a position that is best to do the injection. This often involves exposing the body part appropriately, as well as considering the patient's comfort. Keeping you comfortable and relaxed is integral to performing a successful injection. He or she will then clean or sterilize the skin and then perform the injection. Everyone wants to know how much the injection is going to hurt. The bottom line is that the majority of the time it is a quick pinch and a burn, much like a flu shot, although some injection sites hurt more than others, admittedly. Now, once the injection is complete, a small dressing or band-aid is applied and you're done. Most orthopedic surgeons will mix some local anesthetic, a numbing agent, in the syringe along with a cortisone. This numbing agent can take effect in a matter of minutes and last for several hours, depending on the specific local anesthetic used. So you may feel a measure of relief shortly after the injection. Sometimes that relief can be dramatic. The cortisone's onset is more slow and less obvious. Hopefully the cortisone is kicked in enough so that you're not more sore after the local has worn off. Unfortunately, that does not always happen, and in some patients report more soreness, kind of like a toothache, several hours after the injection. If that happens, it is normal. Place ice on the affected site. Medications like Tylenol, ibuprofen, Aleve, etc. can help. And oh, by the way, you can remove that band-aid later on that night. Now, if you do have that period of toothache pain after the injection that I just described, you may feel better the following morning. Sometimes it can take 3 days or so. If you haven't experienced a second wave of relief by 7 days or so, it's not likely to happen. Once the pain goes away, most patients will be interested in pursuing activities that used to be painful, and they question whether that is appropriate. My short answer is almost always yes. The goal is to make you better so that you can participate in your activities, not just so that you have less pain while sitting on the couch, but confirm this with your doctor. I do think that it makes sense to limit your activities until the cortisone has kicked in and provided relief, however. So you may want to hold off for a couple of days after the injection to start resuming your activities. And once you start returning to your activities, use common sense. Start slowly, add intensity and volume over time, and listen to your body. Bear in mind, it is important that you participate in and complete all of the doctor's recommended therapeutic interventions. Most patients, once they complete their treatments, have durable relief. However, some patients experience a recurrence of their symptoms. Sometimes the symptoms can return in 6 months, sometimes it's 6 weeks, and it can be hard to predict how long your body will respond. If your symptoms do return, repeat injections can be done, but discuss it with your doctor to see if it makes sense to do so in your particular situation. If you are considering a repeat injection, I try to wait at least 3 months in between injections in the same spot. Well, I hope that you found these general comments about the commonly employed therapeutic intervention of cortisone injections to be helpful and informative. If you have specific questions that are not addressed by this video, please direct them to your physician. Thank you for your interest and have a good day.